Your immune system is responding to something right now, not in the acute sense of fighting off an infection or healing a wound, but in a persistent, low-grade activation state that exists in the background of your physiology. This state is called chronic inflammation, and it differs fundamentally from the acute inflammation you experience when you cut your finger or catch a cold. Acute inflammation is protective. It mobilizes immune cells to sites of injury or infection, clears pathogens, removes damaged tissue, and initiates repair. It resolves within days or weeks and leaves you healthier than before. Chronic inflammation is the opposite. It persists for months or years without resolution. It damages healthy tissue, it interferes with normal cellular function, and it is now recognized as a central driver of virtually every major chronic disease, including cardiovascular disease, type 2 diabetes, cancer, Alzheimer disease, autoimmune conditions, and metabolic syndrome. The distinction matters because while acute inflammation is something your body does to you for your benefit, chronic inflammation is something that happens when regulatory mechanisms fail and the immune system becomes stuck in an activated state that serves no protective purpose. What makes chronic inflammation particularly insidious is that it produces no obvious symptoms until significant damage has accumulated. You do not feel inflamed the way you feel a fever or notice swelling around a sprained ankle. The inflammation is systemic, diffuse, and measured not by pain or visible signs, but by blood markers like C-reactive protein, interleukin-6, and tumor necrosis factor alpha. By the time symptoms appear, whether as a heart attack, a cancer diagnosis, or progressive cognitive decline, the inflammatory processes have typically been active for years or decades. The question that has consumed researchers for the past 20 years is not whether chronic inflammation drives disease that is now established beyond reasonable doubt, but what triggers it in the first place and what interventions can reliably reduce it without suppressing the beneficial aspects of immune function. The answers that have emerged from clinical trials and mechanistic research point to 4 specific interventions that lower inflammation through distinct biological pathways, and the evidence supporting them is sufficiently robust that they should be considered foundational to any serious approach to disease prevention. Hi, I am Dr. Alex. I am an emergency medicine doctor, and after nearly 10 years working in accident and emergency, I have seen what happens when chronic inflammation is allowed to progress unchecked. I have treated myocardial infarctions in patients whose coronary arteries were destroyed by decades of inflammatory plaque formation. I have managed strokes caused by inflammatory damage to cerebral vessels. I have seen the accelerated cognitive decline in patients whose brains were subjected to years of neuroinflammation. My goal now is to help people understand that inflammation is not an inevitable consequence of aging. It is a modifiable process driven by specific lifestyle and metabolic factors, and it can be reduced through interventions that are accessible, evidence-based, and far more effective than most people realize. For the next several minutes, I am going to explain exactly what chronic inflammation is at a cellular level, why it drives the diseases it does, and walk you through 4 scientifically validated interventions that reduce inflammatory markers and lower disease risk in ways that have been demonstrated in randomized controlled trials and large population studies. Before we discuss the interventions, we need to understand what initiates and sustains chronic inflammation, because the pathways involved are distinct from those that drive acute immune responses. Chronic inflammation typically begins with one of several triggers. The first is metabolic dysfunction, particularly insulin resistance and elevated blood glucose. When cells are exposed to high glucose levels, they produce advanced glycation end products, which are proteins or lipids that become glycated after exposure to sugars. These molecules activate immune receptors on macrophages and other cells, triggering the release of inflammatory cytokines. Insulin resistance itself promotes inflammation because adipose tissue, particularly visceral fat, becomes infiltrated with immune cells that secrete tumor necrosis factor alpha, interleukin-6, and other pro-inflammatory mediators. The liver, when subjected to constant influx of free fatty acids from visceral fat, develops hepatic steatosis and releases acute phase proteins, including C-reactive protein, which is one of the most commonly measured markers of systemic inflammation. The second trigger is oxidative stress, which occurs when the production of reactive oxygen species exceeds the capacity of antioxidant defense systems to neutralize them. Reactive oxygen species are generated normally during mitochondrial energy production, but production increases dramatically under conditions of chronic nutrient excess, particularly when cells are overloaded with glucose and fatty acids. These molecules damage cellular structures, including lipids, proteins, and DNA. When lipids in cell membranes are oxidized, they become inflammatory signals themselves. Oxidized low-density lipoprotein particles, for instance, are taken up by macrophages in arterial walls, converting them into foam cells that drive atherosclerotic plaque formation. The body recognizes oxidative damage as a danger signal and mounts an immune response, but because the damage is continuous rather than self-limiting, the response becomes chronic. The third trigger is gut barrier dysfunction, often referred to as increased intestinal permeability or colloquially as leaky gut. The intestinal lining is a single layer of cells held together by tight junction proteins. When this barrier is compromised, which can occur due to poor diet, chronic stress, alcohol consumption, certain medications, or dysbiosis of the gut microbiome, bacterial products including lipopolysaccharide can translocate from the gut lumen into the bloodstream. Lipopolysaccharide is a potent activator of the innate immune system. It binds to receptors on immune cells and triggers a cascade of inflammatory signaling that was designed to respond to systemic bacterial infection. When this occurs chronically at low levels due to ongoing gut barrier dysfunction, it creates a state of persistent immune activation that contributes to systemic inflammation. The fourth trigger is chronic psychological stress, which activates the hypothalamic pituitary adrenal axis and the sympathetic nervous system. Cortisol, the primary stress hormone, is actually anti-inflammatory in acute settings, but chronic elevation of cortisol leads to glucocorticoid resistance, where immune cells become less responsive to cortisol's regulatory signals. Simultaneously, chronic stress increases the production of catecholamines like norepinephrine, which bind to receptors on immune cells and promote inflammatory cytokine production. The combination creates a state where the normal feedback mechanisms that would shut down inflammation become impaired, allowing inflammatory processes to persist. What these triggers have in common is that they activate a conserved set of inflammatory pathways at the cellular level. The most important of these is the nuclear factor kappa B pathway, which is a transcription factor that regulates the expression of hundreds of genes involved in inflammation, immune responses, and cell survival. When nuclear factor kappa B is activated, it translocates to the nucleus and initiates the production of inflammatory cytokines, chemokines, and adhesion molecules. Another critical pathway is the inflammasome, particularly the NLRP3 inflammasome, which is a multi-protein complex that assembles in response to danger signals and activates caspase-1, an enzyme that processes pro-inflammatory cytokines into their active forms. Once activated, these pathways create a self-reinforcing cycle. Inflammatory cytokines recruit more immune cells produce reactive oxygen species and more cytokines. Tissues become damaged, releasing additional danger signals that perpetuate the response. Breaking this cycle requires interventions that target the upstream triggers and the signaling pathways themselves. The first science-backed intervention for lowering inflammation is regular physical activity, and the mechanisms through which exercise reduces inflammation are multiple and well characterized. The immediate effect of exercise is actually pro-inflammatory. During intense physical activity, there is muscle damage, increased production of reactive oxygen species, and release of inflammatory cytokines, including interleukin-6 from contracting muscle. This acute inflammatory response is part of the adaptive process that leads to muscle repair and increased fitness. However, the chronic effect of regular exercise training is profoundly anti-inflammatory. Studies that have measured inflammatory markers before and after exercise training interventions consistently show reductions in C-reactive protein, tumor necrosis factor alpha, and interleukin-6 at rest. The mechanisms involve several pathways. First, exercise reduces visceral adipose tissue, which is one of the primary sources of systemic inflammation. Even modest amounts of exercise, when performed consistently, reduce visceral fat preferentially, and this alone accounts for significant reductions in inflammatory markers. Second, exercise improves insulin sensitivity, which reduces the metabolic triggers for inflammation associated with hyperglycemia and insulin resistance. Third, contracting skeletal muscle releases myokines, which are signaling molecules that have anti-inflammatory and metabolic regulatory effects. Interleukin-10 and interleukin-1 receptor antagonist are examples of anti-inflammatory myokines that are released during exercise and circulate systemically to dampen inflammatory responses in other tissues. Fourth, exercise promotes autophagy, which is the cellular process by which damaged proteins and organelles are degraded and recycled. Enhanced autophagy reduces the accumulation of damaged cellular components that would otherwise trigger inflammatory responses. The dose of exercise that appears most effective for reducing inflammation is moderate intensity aerobic activity performed for at least 150 minutes per week, consistent with public health guidelines. Studies have shown that this volume of exercise reduces C-reactive protein levels by approximately 20 to 30% in previously sedentary individuals. Higher volumes and intensities provide additional benefits, but the relationship is not linear, and excessive training without adequate recovery can actually increase inflammatory markers due to inadequate repair time. Resistance training also reduces inflammation, particularly when it increases muscle mass, because muscle tissue itself has anti-inflammatory properties, and improved muscle insulin sensitivity reduces metabolic inflammation. The critical factor is consistency. Sporadic exercise does not produce the sustained reductions in inflammatory markers that regular training does, because the anti-inflammatory adaptations require ongoing stimulus to be maintained. The second intervention is dietary modification, specifically a shift toward anti-inflammatory dietary patterns and away from pro-inflammatory foods. The evidence here is extensive and comes from both observational studies and randomized controlled trials. The most well-studied anti-inflammatory dietary pattern is the Mediterranean diet, which emphasizes vegetables, fruits, whole grains, legumes, nuts, olive oil, and fish, while minimizing red meat, processed foods, and refined sugars. Multiple intervention studies have shown that adherence to a Mediterranean diet reduces inflammatory markers including C-reactive protein, interleukin-6, and tumor necrosis factor alpha. The mechanisms are multifactorial. First, the diet is rich in polyphenols, which are plant compounds with direct anti-inflammatory effects. Polyphenols inhibit nuclear factor kappa B activation, reduce oxidative stress, and modulate immune cell function. Second, the diet provides high amounts of omega-3 fatty acids from fish, particularly eicosapentaenoic acid and docosahexaenoic acid. These fatty acids are incorporated into cell membranes and serve as precursors to specialized pro-resolving mediators, which are lipid molecules that actively promote the resolution of inflammation and prevent it from becoming chronic. Third, the diet is high in fiber, which supports a healthy gut microbiome. Fiber is fermented by gut bacteria into short-chain fatty acids like butyrate, which have direct anti-inflammatory effects on intestinal cells and systemic immune function. Fourth, the diet is low in refined carbohydrates and added sugars, which reduces postprandial glucose and insulin spikes that drive metabolic inflammation. Conversely, dietary patterns that promote inflammation have also been clearly identified. Diets high in refined carbohydrates, particularly those with high glycemic loads, increase postprandial glucose and insulin levels, which activate inflammatory pathways. Diets high in saturated fats and trans fats promote inflammation through mechanisms involving altered cell membrane composition, increased oxidative stress, and activation of toll-like receptors on immune cells. Diets high in advanced glycation end products, which form when foods are cooked at high temperatures, particularly through grilling, frying, or roasting, directly activate inflammatory receptors. Ultra-processed foods, which typically combine refined carbohydrates, unhealthy fats, high sodium, and various additives, have been associated with elevated inflammatory markers in multiple studies, likely through combined effects on metabolic function, gut health, and oxidative stress. The practical implication is that reducing inflammation through diet requires both adding anti-inflammatory foods and removing pro-inflammatory ones. Simply adding fish oil or polyphenol supplements while continuing to consume a diet dominated by ultra-processed foods is unlikely to produce meaningful reductions in inflammatory markers. The third intervention is optimization of sleep quality and duration, and the connection between sleep and inflammation is bidirectional and mechanistically clear. Sleep deprivation, even partial sleep restriction to 5 or 6 hours per night, increases inflammatory markers within days. Studies using experimental sleep restriction have shown elevations in C-reactive protein, interleukin-6, and tumor necrosis factor alpha after just a few nights of inadequate sleep. The mechanisms involve several pathways. First, sleep deprivation activates the sympathetic nervous system and increases cortisol production, both of which promote inflammatory signaling when chronically elevated. Second, inadequate sleep impairs the function of regulatory T cells, which are immune cells that suppress excessive inflammatory responses. When regulatory T cell function declines, the immune system becomes more prone to inappropriate activation. Third, sleep is when the glymphatic system, which is the brain's waste clearance pathway, is most active. During deep sleep, cerebrospinal fluid flushes metabolic waste products and inflammatory mediators from the brain. When sleep is disrupted, this clearance is impaired and inflammatory molecules accumulate in neural tissue. Fourth, poor sleep disrupts circadian rhythms, which regulate immune cell function and cytokine production. When circadian rhythms are misaligned, the normal oscillations in inflammatory signaling become dysregulated. The relationship between sleep and inflammation is also evident in conditions characterized by sleep disruption. Obstructive sleep apnea, which causes repeated episodes of hypoxia and sleep fragmentation, is associated with markedly elevated inflammatory markers and dramatically increased cardiovascular risk. Treatment of sleep apnea with continuous positive airway pressure reduces inflammatory markers and improves metabolic and cardiovascular outcomes. Insomnia, particularly when it is chronic, is associated with elevated C-reactive protein and interleukin-6, and interventions that improve sleep quality through cognitive behavioral therapy reduce these markers. The dose of sleep that appears optimal for minimizing inflammation is 7 to 8 hours per night of high-quality sleep, characterized by adequate time in deep sleep and REM sleep stages. Both short sleep duration, typically defined as less than 6 hours, and long sleep duration, defined as more than 9 hours, are associated with elevated inflammatory markers, suggesting a U-shaped relationship where extremes in either direction are problematic. The fourth intervention is stress reduction and psychological well-being, which affects inflammation through neuroimmune pathways. Chronic psychological stress, whether from work demands, relationship difficulties, financial insecurity, or caregiving burdens, activate inflammatory processes through multiple mechanisms. Acute stress triggers the release of cortisol, which in the short term is anti-inflammatory. However, chronic stress leads to a phenomenon called glucocorticoid resistance, where immune cells downregulate their cortisol receptors and become less responsive to cortisol's regulatory signals. This allows inflammatory processes to proceed unchecked even when cortisol levels are elevated. Chronic stress also increases sympathetic nervous system activity, which directly stimulates immune cells to produce inflammatory cytokines. Psychological stress affects health behaviors as well, often leading to poor dietary choices, reduced physical activity, and disrupted sleep, all of which contribute to inflammation through the pathways already discussed. Interventions that reduce psychological stress have been shown to reduce inflammatory markers in controlled trials. Mindfulness-based stress reduction, which combines meditation, body awareness, and yoga, has been shown in multiple studies to reduce C-reactive protein, interleukin-6, and nuclear factor kappa B activity. The mechanisms appear to involve both direct effects on autonomic nervous system balance, shifting from sympathetic to parasympathetic predominance, and indirect effects through improved sleep, better health behaviors, and enhanced emotional regulation. Cognitive behavioral therapy, particularly when it successfully reduces symptoms of depression and anxiety, also reduces inflammatory markers. Social connection and perceived social support are protective against inflammation, while social isolation and loneliness are associated with elevated inflammatory markers independent of other risk factors. The biological pathways involve both stress hormone regulation and direct effects on immune cell gene expression, as studies have shown that loneliness alters the expression of genes involved in inflammation and antiviral responses. In emergency medicine, we rarely measure inflammatory markers acutely because the diseases we treat are the end results of processes that have been developing for years. We see the myocardial infarctions that result from inflammatory atherosclerotic plaques rupturing. We see the strokes caused by inflamed, unstable plaques in carotid arteries. We see the diabetic complications that arise from years of metabolic inflammation, damaging nerves, kidneys, and retinas. We see the cancer diagnoses in patients whose chronic inflammatory state promoted tumor development and progression. What becomes evident when you work on the front line is that inflammation is not an abstract laboratory finding. It is a disease mechanism that translates directly into clinical events. The patients who avoid these outcomes are not simply lucky. They are the ones who, often unknowingly, maintained lower levels of chronic inflammation through lifestyle patterns that address the triggers I have described. The challenge in clinical practice is that chronic inflammation is invisible until it produces disease, and by that point, interventions become damage control rather than prevention. Measuring inflammatory markers like high-sensitivity C-reactive protein can identify individuals at elevated risk before clinical disease develops, and guidelines from cardiology societies now include C-reactive protein as a risk refinement tool for cardiovascular disease prediction. Values above 2 mg per litre indicate elevated inflammation and increased risk, while values above 3 mg per litre are considered high risk. However, measurement alone is insufficient. What matters is implementing interventions that address the underlying causes. The 4 interventions I have described, regular physical activity, anti-inflammatory dietary patterns, adequate high-quality sleep, and stress reduction, are not independent. They interact and reinforce each other. Exercise improves sleep quality and insulin sensitivity, which reduces metabolic inflammation. Better sleep enhances exercise recovery and improves dietary choices. Stress reduction improves sleep and often leads to better adherence to exercise and dietary interventions. A Mediterranean dietary pattern provides nutrients that support better sleep and may improve mood and stress resilience. The synergy means that implementing multiple interventions simultaneously produces greater reductions in inflammatory markers than any single intervention alone. The evidence base for these interventions is not speculative or preliminary. These are established, replicable findings from large randomized controlled trials and prospective cohort studies involving hundreds of thousands of participants followed for decades. The reductions in inflammatory markers translate into measurable reductions in disease incidence. Studies have shown that individuals who maintain higher levels of physical activity, healthier dietary patterns, adequate sleep, and better stress management have substantially lower rates of cardiovascular disease, type 2 diabetes, cancer, and dementia, and much of that protection is mediated through reduced chronic inflammation. Chronic inflammation is more than a biomarker. It is a central pathological process that connects lifestyle factors to disease outcomes through well-defined molecular mechanisms. The triggers include metabolic dysfunction, oxidative stress, gut barrier dysfunction, and chronic psychological stress. The pathways involve nuclear factor kappa B, inflammasomes, and cytokine cascades that damage tissues and promote disease when they become chronically activated. The 4 interventions that reliably reduce inflammation, physical activity, anti-inflammatory diet, sleep optimization, and stress reduction work through distinct but complementary mechanisms to address these triggers and interrupt the inflammatory pathways. None of these interventions require pharmaceutical agents or expensive treatments. They are accessible, modifiable, and effective when implemented consistently. The time to address inflammation is not after disease has been diagnosed. It is now when the processes are still reversible and the opportunity to prevent rather than manage disease remains available. Finally, if you found this information valuable, and you believe others could benefit from understanding the science connecting lifestyle to inflammation and disease, please subscribe to the channel. Every subscription helps this content reach more people who need evidence-based information about preventing the chronic diseases that dominate modern medicine. I am committed to continuing to provide scientifically rigorous content that translates research into actionable knowledge. Thank you for watching.